So in terms of septic shock management, the Surviving Sepsis campaign is a joint collaboration of the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, and it's committed to reducing mortality from severe sepsis and septic shock worldwide. Annually, these professional organizations will meet and they'll publish surviving sepsis guidelines for the management of severe sepsis and septic shock. The Institute for Healthcare Improvement, in collaboration with this campaign, creates bundles to help healthcare providers in implementing these guidelines. So 2 sepsis treatment bundles will be outlined, the sepsis resuscitation bundle and the sepsis management bundle, with the sepsis resuscitation bundle, or the one shown on the left, being the most effective treatment regimen for patients with septic shock. The sepsis management bundle, shown on the right, has a lot more risk factors associated with it and therefore is not being utilized in the clinical setting. So the sepsis resuscitation bundle consists of 5 essential components. The first is to measure serum lactate, and a level of greater than 4 will indicate that the patient's metabolism has shifted to be anaerobic, which indicates that hypoperfusion is present. The lactate level is going to be the best indicator for identifying somebody in sepsis or septic shock. The second thing is to obtain blood cultures as soon as possible prior to giving antibiotics, preferably, but most of the time patients who have sepsis or septic shock will have positive blood cultures. The third is to deliver broad-spectrum antibiotics as soon as possible, more specifically within 3 hours of emergency room arrival or within 1 hour if the patient is already hospitalized. Now, again, culture-specific antibiotics are preferred, but while you're waiting for those blood culture results to return, just give the patient broad spectrums and then reevaluate once the blood cultures return from the lab. The fourth step is to perform a fluid challenge and to administer colloids, crystalloids, and vasopressors, with norepinephrine being the vasopressor of choice. Now, this is the goal here is to increase the blood pressure, maintain a mean arterial pressure, as well as maintain a heart rate. The fifth component is to stabilize the central venous pressure to be greater than or equal to 8, or between 12 and 15 if the patient is ventilated. And another thing is if the patient's hematocrit drops to less than 30%, packed red blood cells can be administered to stabilize the blood pressure and the venous pressure as well. Now, the sepsis management bundle consists of 4 steps, the first being low-dose steroids. And the issue with administering low-dose steroids is that there's an increased risk for hypoglycemia, but more importantly, an increased risk for nosocomial infections as well as recurrent sepsis, as we know that steroids will cause further immunosuppression and will put the patient at risk for superinfections as well. The second was, it was recommended to administer drotocodin alpha, which is a recombinant form of human activated protein C. It has antithrombotic and anti-inflammatory properties. However, it was pulled from the market after a major study showed no efficacy for its treatment for sepsis. And the third thing is to control blood glucose by maintaining a level greater than 80 or less than 180 via insulin infusion, but again, the risk here is hypoglycemia. The fourth step is to control the inspiratory plateau pressure in patients who are ventilated by having a low tidal volume of less than 6 milliliters per kilogram. And the goal here was to prevent lung injury or any respiratory distress in a patient who was ventilated. So again, the gold standard is the sepsis resuscitation bundle shown on the right, measuring the lactate, identifying the issue, drawing blood cultures to target a specific bacteremia, administering broad-spectrum antibiotics at the beginning as soon as possible, conducting a fluid challenge and giving fluids as well as vasopressors to increase the blood pressure, and then maintaining the central venous pressure as well. So a few other treatment options that are helpful in the management of septic shock include CTs and MRIs, as brain dysfunction is a frequent and severe complication of septic shock. It occurs in up to 60% of patients and is associated with an increased mortality rate as well as long-term cognitive impairments. It's clinically characterized by an acute alteration of consciousness ranging from coma to delirium, and less frequently by seizures or focal neurologic signs. So it's very essential to get CTs and MRIs in order to recognize if a patient has any brain dysfunction associated with sepsis or septic shock. Another treatment option is to drain any abscesses, as well as debride any necrotic wounds, as these may be the sources of infection. Also to remove contaminated devices that include central lines, other IV lines, as well as Foley catheters as soon as the patient is stabilized. And in terms of comfort measures, you want to treat the fever, and you'll alternate between Advil and Tylenol in order to reduce the risks of nephro and hepatotoxicity. Another thing we could utilize are cooling blankets, which will help the patient feel more comfortable as well as help with their metabolic rate. And just the thing here is to keep in mind that we don't want to have it increase or lower the core temperature too much, causing hypothermia. So you'd want to shut it off if the temperature drops 1 degree lower than anticipated. And in terms of nutrition, many patients with septic shock will need total parenteral nutrition or enteral nutrition. And so this is another management technique that we need to utilize in collaboration with nutrition and dietitians. Now, in terms of referrals and an interdisciplinary approach, it's really important to take a collaborative approach, collaborating with senior clinicians who will be experts in septic shock patients' care, such as intensivists, pulmonologists, and infectious disease physicians. You also want to consult with respiratory therapy if the infection is located in the respiratory tract or if the patient is ventilated to maintain that airway. You want to be in close communication with the lab or pathology to ensure that your blood cultures are being received and drawn appropriately, as well as your results being delivered adequately. Pharmacy, of course, to manage any medications the patient is on, especially the antibiotics, to ensure that they're working against the infection. And the last thing is psychiatry for the patient. You really want to provide a supportive environment for the patient and their family, as this is a really difficult time and the patient can very rapidly deteriorate. So in terms of patient education, nurses should discuss the goals of care with the patient and the family. The prognosis should be discussed with the patient if possible, and if appropriate, end-of-life care and palliative care should be discussed as early as possible in order for interventions to be made early on with the family involved at the bedside. You're going to want to assess the patient's anxiety level and also their knowledge deficits regarding sepsis and septic shock, and educate the patient about the pathophysiology, potential complications, the treatment options, the risks and the benefits of treatment options, while the entire time, of course, taking an individualized approach unique to their specific prognosis and providing emotional support to the patient and their family. In terms of prevention and health promotion, if implemented promptly and appropriately, simple strategies can help reduce sepsis and septic shock. Early detection and intervention are critical in preventing septic shock, and proper hand hygiene is the simplest and most important infection control strategy that nurses can take. They should also provide meticulous care for immunosuppressed patients, such as those with cancer. The use of aseptic technique when caring for peripheral and central lines is also essential. IV lines and Foley catheters should be removed as soon as possible once the patient has stabilized. And another goal is to reduce ventilator-associated pneumonia. And in order to do so, nurses should provide comprehensive oral care and oropharyngeal decontamination with oral chlorhexidine gluconate. Nutrition and hydration can also decrease the risk of hospital-acquired infection, and early and frequent ambulation will improve circulation and help prevent atelectasis and pneumonia. And lastly, it's essential to train and educate the hospital staff on detecting the early signs and symptoms of sepsis and septic shock, as well as knowing how to recognize patients at most risk for developing sepsis. These are all critical steps in preventing septic shock. And many healthcare organizations have implemented a routine screening regimen, as well as early warning systems and expert sepsis care teams to help prevent and manage septic shock patients. So in conclusion, nurses play an essential role in detecting patients who are deteriorating. We're the first line of defense in initiating life-saving treatment protocols and communicating with the appropriate physicians. It's also essential to be aware of the guidelines and any new evidence-based practice that are being used and researched in order to provide the best, most effective, and safest care to our patients. It's essential for all staff to intervene early in order to prevent harm and reduce mortality of septic shock.